Hello, class. Andy here, giving our presentation on spinal and epidural anesthesia. During my exams and studies, I kind of hit on some specific points that I remember. We've all done epidurals and spinals, but I'm going to hit on some topics that I remember seeing on some of my questions on C and in my review textbooks. So here we go. First, let's go over the anatomy. Quick reminder of that we have 33 vertebrae, 7 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 4 coccygeal. Spinal cord runs from the in the adult to L1, and in the newborn L3. And when we're feeling to start an epidural or spinal, we use the landmarks of the iliac crest, which creates a line. Can you remember what that line is called? That's correct, Tufier's line, which runs into the T or to the L4 spinous process. And then you can go to 3-4 or 4-5 following that. Some more anatomy. We've seen this hundreds of times. Through the skin, so you go skin, subq, supraspinous, interspinous ligaments, and ligamentum flavum, and then the epidural space, dura mater, and then the arachnoid matter. When you're performing a epidural or spinal, you can do a paramedian approach. Some of you may have done this, which can be a board question. What structures do you bypass by doing a paramedian approach? And the answer is supraspinous and interspinous ligaments. A little points of trivia. What are the highest points of the spine, or if the patient is laying supine, which ones are the more closer to the chest? That would be C3 and L3. And then the lowest points would be T6 and S2. And I read that in the Valley review book. Some more trivia. What epidural space is widest, or where in the epidural space is the widest point? And the answer is L2, and it's 5 to 6 millimeters wide. So your best chances of getting a spinal or finding the epidural space may be better L2, L3 area in an adult. And the smallest is actually C5, and it's 1 to 1.5 millimeters. So this is where I got into some of the questions. What are some absolute contraindications for doing a spinal or epidural? And it's kind of interesting how different sources all say some different things. Of course, we have patient refusal. We all remember that. Infection at the site of insertion, increased ICP, gross abnormalities in clotting function, abrupted placenta, severe aortic stenosis, severe mitral stenosis, IHSS, and then severe atrial stenosis. And the stenosis is being kind of, in the more recent literature, debated due to the fact that the stenosis, you're still going to get a drop in blood pressure potentially by doing a general. So is it better to do an epidural and dose it where you're walking it up from the waist up to wherever your desired level is? Would that be safer for a patient rather than doing a general? So you may see some more articles on that in the future, depending on how research is going there. Now to anticoagulation. I saw this on several questions, so I'll go through some medicines that we see regularly and kind of the recommended times for doing where it is safe to do a spinal or epidural. Of course, NSAIDs, aspirin, You may receive neuraxial anesthesia regardless of last dose. Warfarin, DC 4 days prior to surgery, and then you may do a neuraxial block if the INR is less than 1.5. So you kind of judge it off of blood levels, and then you wouldn't remove the catheter until the INR is less than 1.5. So you're going to draw blood before and before you do the epidural, and then before you remove the catheter. Intravenous heparin, normal PTT before administration. So you want to wait 1 hour after the block is complete to do or to restart your heparin, and then catheter removal for an epidural 2 to 4 hours after the last dose, and then you can restart your heparin 1 hour after the catheter is removed. Some more drugs that we might see: your fibrinolytics 10 days before. You must DC those before they can get spinal, or it's safe to give spinal or epidural. Some other drugs, Riapro, 24 to 48 hours after DCing is when you start seeing regular platelet function. So safe side, maybe 48 hours to watch for function. Integralin, 4 to 8 hours, 4 to 8 hours after DCing is when you start seeing.
48 hours. 48 Hours is an American documentary, news magazine, television series broadcast on CBS. The series has been broadcast.
Thanks, Google.
To read more, look for the link in your Google Home app.
All right. So there we go. So Integralin, 4 to 8 hours after DC, you start seeing platelet function back to normal. Ticlid, or ticlodipine, 14 days, and then Plavix is 7 days. And then you may see this a lot in your patient's low molecular weight heparin. So the initial block, 12 hours after the last dose, and then depending on how often they're receiving their dose of medicine, either twice daily or once, will change a little bit. So for twice daily dosing, no, let's see, remove catheter next day, so about 24 hours after the last dose, and then you would restart 2 hours after the catheter is removed. And then your once daily dosing, first dose would be 6 to 8 hours post-op if they're having surgery. For catheter removal, no earlier than 10 to 12 hours after the last dose, and then 2 hours after catheter removal you can restart. So some complications that we see regularly. Number one, what do you think? Yep, you guessed it, backache. That's the most commonly reported complication. Some other serious ones are hematomas. And now they're saying, and as we know, MRI is the best diagnosis for hematoma formation. And some of the infections at the site are common as well due to improper technique or sterilization prior to. The most causative one for epidural abscess is staph aureus. So, and then the most commonly for spinal meningitis is alpha hemolytic streptococcus. So kind of remember those, because I remember getting asked about staph being the most common problem in epidural abscesses. And then the one that affects us probably the most is our postdural puncture headaches. They can be seen. I've actually watched somebody get a puncture headache watching a CRNA do an epidural, and it was instantaneous. But literature says that you can see symptoms all the way up 1 to 2 days after the initial puncture. So just because you think everything went well doesn't mean necessarily that the patient can't be symptomatic later. Especially those epidurals that you do that you place, and right before you put in your catheter, you notice some fluid coming through your Tuohy needle, and you think, oh, well, maybe that's my local, or maybe that's could be spinal fluid, but I think it's okay, and you do your test, everything goes okay. Those are the ones that you'll probably see that. So, excuse me. So our normal things to help with puncture headaches: bed rest, of course, hydration, oral analgesics, and caffeine. 500 milligrams added to 1,000 bag of IV fluids, and you give it about 200 mils an hour is what the book recommends. And that's usually good for your mild headache patients. And as a research article that I read, and I'll talk about later, actually states that somewhere around 80%, I believe, is what the article says, it will fix a puncture headache. So for your patients that are multiple sticks, or you have an obvious wet tap, hydration and caffeine will somewhat work, and they work by stimulating CSF production, and then caffeine will help with the intracranial vessels, constricting those. Blood patch. So next thing that you'll see for your moderate to severe puncture headache patients is blood patches. I've done several of these, and I'm sure several of you have done these before too. For those of you who haven't done many of these, or any at all, it's basically finding epidural space and injecting blood to patch the hole created by the puncture. And most of the time I've done it with another anesthesia provider, but if you're by yourself, I've seen different techniques done with that. Of course, you would do all of it sterilely, which is kind of difficult. So most of the time I've seen the one anesthesia provider cleaning and prepping an IV site to draw sterile blood, and then one provider finding epidural space, gets lost, removes their glass syringe, and then waits for the blood. The book recommends 10 to 30 mils. At our facility, we fill a 30 mil syringe and then give it until the patient. You can almost see the relief almost instantly, and they will tell you that they get relief, but they will have pressure in their back, and that's where the book recommends to give blood until the patient starts feeling painful pressure in the back. They may feel pressure when the blood starts being injected, but once that space gets full, it's going to start pressing on those nerves and be painful. And 89 to 95% of patients will get pain relief on the first attempt. And you're supposed to do bed rest for 1 to 2 hours after. Most of the time they'll leave patients in the hospital just to sit in the ER or wherever they're at for 1 to 2 hours, and then no strenuous exercise for 24 hours. And then if the symptoms aren't relieved, you can do it again in 24 hours. And the recommended place to do that, this was my question when we started doing them, was where to inject. Do I inject above and let it flow down? Do I inject below and inject quick enough where it rises, or at the same level? And our books all say that you should do it at the site of injection or one space below the level. And of course, then you would push until pressure in the back. A research article I found was kind of an accumulative study. They did their own study and then referenced several other studies. And this, they did 40 patients. They did an epidural blood patch on. They were all elderly, geriatric patients. And most 85% had relief from the blood patch within 24 hours. 33 patients had conservative treatment prior to the blood patch, and 85% saw relief. And then the ones that required a blood patch, or 95% of them had relief. Other study findings in Finland, 3 out of 10,000 older than 65 needed a blood patch, which they referenced that age had a lot to do with the amount of people needing a blood patch. Increasing age required less of your more drastic more drastic things like blood patches and using high doses of caffeine and things. More conservative treatments were actually fixing the problem in your geriatric patients in almost 99% of the patients. Younger patients will more likely require a blood patch. And then most patients had complete relief from symptoms 7 days after conservative treatment. So just doing your caffeine, hydration, and bed rest actually solved, or a majority of the cases at 7 days solved pain relief. And next there is my resources. Thank you for watching. If you have any questions, hit me up at graduation, hopefully.